I'm Justin Calvert. I'm kind of originally from Mississippi, but I trained at Vanderbilt, did my diagnostic radiology residency there, and then I moved to Chicago and did my body interventional radiology fellowship there, and then came here, and Dr. Baxter and Dr. Crawford hired me basically to do body IR, being attending from here down and a fellow from here up. So this year I'm kind of learning how to do the neuro, and I'm also functioning as a body interventional attending. So we do a lot of different things in interventional radiology. I think one of the main things Amy wanted me to talk to you about is, we do a lot of work inside the arteries, and so we'll stick the confemoral artery to do the majority of our procedures, whether it's in the brain or in the liver or the kidney or anywhere. The confemoral artery is kind of the go-to artery, and the main thing is when we come out of the confemoral artery, a lot of times we'll seal the groin. Traditionally, you can hold pressure on the groin, and what that does is, eventually, after 15 minutes or so, most people will stop bleeding. The idea is we're trying to get people to the unit faster, because when they get to you guys, y'all can warm them up, y'all can, stabilize their blood pressure, and the intensivists can come around and make sure everything else is going. So we try to, once we finish, we try to decrease that downtime from getting from the ICU, from us back to the ICU. So we'll use a closure device. And the main one that we use now is called AngioSeal, and it's basically just a gel foam plug that we put in, and we'll deploy in the confemoral artery, and it's a plug of gel foam that gets squished down on top of the artery, and it has a little foot plate that goes inside of the artery. And so and what that does is that gel foam plug squeezes up against our arteriotomy site, and it causes the blood to clot faster around the artery, so we don't have to hold pressure basically at all. Which is kind of nice, because we'll put that plug in there, and we'll basically put a little bandage on there and send it straight to you guys, and we're done. The main thing is sometimes it's not foolproof, so it doesn't always work. And I would say it works about 90% of the time. 10% of the time, well, probably more like 5% of the time, it kind of partially works, and then another 5% of the time it just doesn't work at all. So basically, if it doesn't work, you're just back to holding manual pressure. The thing is with the groin is, it's sometimes like when a groin is bleeding, you don't see it bleeding like right before your eyes. It's not like gushing out blood, but it's bleeding underneath the skin. And the way you know that it's bleeding is because it's hard and it's tense, and it's like rock hard. And whenever you feel a groin and it's like literally rock hard, then that's not normal. And you have to hold pressure, because it's not going to get better, and it's not going to quit bleeding until somebody hops on it and holds pressure for another 30 minutes or so max. The main thing is, once it's hard like that and you hold pressure, eventually it will get soft. I mean, you just have to trust me on this. It will get softer again. And when it gets softer, that's when you know that it's stopping the bleeding, because that blood is just diffusing out into the subcutaneous fat, and it will soften up. And that's how you know that you've gotten control of the groin, basically. Notify us. We got a call last week. One of the nurses promptly, and it was good that she called us, because we went up. She did a quick groin check. She wasn't sure, because there was a lot of ecchymosis, a lot of bleeding, like a lot of bruising around the groin. It wasn't necessarily bleeding, because it was really soft. But sometimes if they've had that hematoma, if it's bled intermittently and it's stopped, you do get a bruise there. You'll get some like ecchymosis is what we call it. It's just some purpleness. But as long as the groin is soft, then it's okay. It's not really bleeding. So that's really groin stuff that we really want y'all to know about. Again, just give us a call if y'all are unsure about that. A lot of stuff we do is we do a lot of work in the brain. We got a lot of stroke patients here. We're one of the #1 stroke centers in the country. And I'm not really sure why that is, if it's a fact of our diet in this part of the world, or if it's because we're in this tri-states kind of area. But we have a lot of stroke patients, which is good business for Erlanger, and I feel like it's one of our big marketing things. So
it's an old coil, but
oh yeah. So this is a coil. We'll get to that in a second. So when somebody has a stroke, usually the ones that we intervene on is you've got your carotid arteries that come up, your internal carotid arteries, and then they'll branch kind of into the anterior cerebral arteries, which will go kind of this way, and then you'll get your middle cerebral arteries, which go this way. So you got your MCA, your ACA, your ICA. I would say probably 80-90% of the strokes that we deal with, there's a clot right here. in what we call the M1 segment of the MCA. And so what we do is we'll put a catheter through the groin, again, through the confemoral artery and up, and we'll park our kind of main catheter here in the bottom of the internal carotid artery. Then we'll put another catheter through here, and we'll basically suction out this clot out of their brain, literally. If we're successful, then we'll see blood flowing through here again, and everything will open back up. This is just like one of our concentric, this is like our main catheter right here that we use that comes out. I'll show you what that looks like. No, is it just the wire? I think this is just the wire that comes with it. Oh well. The main thing is blood pressure control, okay? Basically the neurologists manage this more than we do, but we will write in our orders, whether we've gotten the clot open, how to control their blood pressure. The main thing is when somebody has a clot in their brain, then their body is going to have like a neurological response to increase their blood pressure, because what they're trying to do is they're trying to get blood flow around this clot through other arteries. For instance, if there's a clot here, then you're going to get increased blood flow going through your anterior cerebral artery and through these little perforators trying to get to the MCA territory. You'll even get more blood flow coming up from your external carotid arteries that branch from your scalp into the middle cerebral artery territory, because this is your body just trying to get more blood to this area that's ischemic, okay? And so that's why your body is increasing that blood pressure. And that's why it's really important that if we don't get this clot out, that we keep our blood pressure high, because we want that collateral blood flow to come to this territory. Now, it's kind of an opposite thing if we get the clot out, and we're usually successful. I would say we're successful around 80% of the time. So if we can get this clot out, then we've restored the normal blood flow through this artery into the MCA. So now there's blood flow going here where there wasn't before. Now the only thing is now is, since this area was ischemic, but it's not anymore because we restored the blood flow, these blood vessels are kind of fragile. And so when you get that clot out of there and you've got more blood flow coming through here and it's a high pressure, then we want to get the blood pressure down, because if we have a high blood pressure going into this area that has kind of very fragile capillaries, then you can get a bleed here. And that's one of the worst things that can happen to somebody after they've had a stroke, is to have a bleed, because then they've got all these, cerebral edema, and they have to call the neurosurgeon, they have to get decompressed, and they'll have to get a drain. So, that's why we really kind of harp on blood pressure control when it comes to these stroke patients. Again, if we don't get the clot out and the clot's still there, we want to keep the blood pressure high. If we get the clot out, then we want to get their blood pressure down to kind of more of a normal range. I would say anything below 140 systolic is fine. Another thing we do is we coil a lot of aneurysms here. And those are a lot of fun. Those procedures they're very technically challenging, but when you're successful at them, you feel good, because you feel like you've done a patient a really good service. So I will say, I'm trying not to trip on these cords here. So let me kind of redraw my picture here. So again, we've got internal carotid artery coming up here, anterior cerebral artery, middle cerebral artery. And so these are your internal carotid arteries. And in the back of your brain, you've got your vertebral arteries that come up. They come together and they form your basilar artery here. So these are your verts, and this is your basilar. So there's areas in your body that you're more prone to get aneurysms than others, and they're at branch points, basically. You've heard us probably talk about a basilar tip aneurysm. So the basilar tip, it'll go into your posterior cerebral arteries. This is what the posterior circulation looks like in the brain. So a basilar tip aneurysm is one that's right there. That's a very common aneurysm. Another common aneurysm is basically one that kind of comes off your anterior cerebral arteries will connect right here, and you'll get an aneurysm that comes off the anterior communicating artery, which is this artery right here. Sometimes we'll get ones off the carotid terminus, and then other times the MCA will branch out here, we'll get some out here. So basically the branch points is basically where you get these aneurysms. There's two ways to treat aneurysms, okay? The neurosurgeons can operate on the aneurysms, and what they do is when they operate them, they'll go through the skull and, dissect out the dura, and they'll cut actually through parts of the brain. And once they get to the blood vessels and they can isolate the blood vessel, then they'll put a little metallic clip. And that metallic clip kind of looks, it's just like you would imagine what a clip looks like. It just kind of clips across the aneurysm itself, except it doesn't clip off a native blood vessel like I drew it, but it just clips off the neck of the aneurysm so that blood flow can just go around it. That's a great way to treat aneurysms. It's certainly very effective because after you treat it, they don't ever have to have a follow-up again. They can just get regular CTs, MRIs to make sure that looks good and they're good to go. The problem is it's a big surgery. They're going to come to you guys and recover for at least a week maybe. Another way to treat the aneurysms is they can come to us and we can coil them. What we do is just like before, we'll get up our base catheter here. It's actually a smaller catheter than we use in stroke. But, and then through that catheter, we'll put a tiny little microcatheter, and we'll actually park the catheter inside the aneurysm itself so that it terminates in there. And then we'll take, and then through that catheter, we'll put in a coil. And this is a coil. So I don't know if this is going to work out for me, but. So this is actually a coil that's been sheathed, but we'll unsheath it. The coil comes out of this little plastic thing, and then it passes through the microcatheter. And as it goes into the microcatheter, as it comes out of here at the end, it just coils up, kind of here. And we'll usually put in a bigger coil at first, just to kind of make a frame, and then we'll put little tinier coils to kind of fill in the gaps. And we can usually get it done. Now they've got new coils that Penumbra's company has come out with that are long and soft, and they're very controllable. And we can usually get away with coiling most aneurysms like maybe 2 or 3 coils. So that's pretty good, because back in the day it was more like 10, and it took a lot longer. But now we've gotten a lot faster at them. The main thing is when they come to you guys, they're basically just going to stay overnight. And if there's any acute changes, we just want to know about it. If they have any kind of, headache that's out of the ordinary. It's funny because a lot of them will have headaches the next day, and it's because they didn't get their coffee. And it's funny because they know that, and they're like, I didn't get my coffee. I've got this caffeine headache. But most of our patients do just fine. Again, if there's any acute changes, you'll know about it, because if you bleed in the brain, you're going to have lots of changes in your blood pressure, and they're going to have major mental status changes, things like that. I mean, this isn't something that is going to be subtle. Fortunately for us, we've had some really good results since I've started, and most all of our patients have done good. But again,
you're still going to do your normal Q15-minute when they first come to you, and then every hour. We usually ask for at least the first 4 hours doing neuro checks every hour when they've had a coiling, and then you can slowly work your way to your every 4 hours as long as they're doing good. And then hopefully the next morning you'll see me, and one of our physicians will come up with me, and we'll get them out of the unit.
It's nice because they can, after they've got their aneurysm coiled, they can just go home the next day usually, and which is nice. It's good for the patient because we did everything through a groin stick. They didn't get this big cut in their head. They don't have to stay in the hospital for a week, so it's good. But that's pretty much it. I mean, I don't want to talk to you guys, bore you guys on one and long. Do y'all have any questions for us? I feel like y'all manage a lot of our drains here. And when I was in my fellowship in Chicago, we rounded on all of our drains, and we were, very kind of meticulous about how they were managed. But I guess the culture here is, the clinicians, the intensivists, and then the hospital, the doctors on the floor like to manage it themselves, which is fine. But I feel like a lot of times, people don't know whether a drain should be pulled or not. Or do y'all have any questions about that, like our abscess drains and things like that? Do y'all have any questions about that? Okay. Main thing is, if you get a drain put in for an abscess, for instance, it'll start draining, and you basically want it to be draining over 15 cc's a day. Once it drains less than 15 cc's a day, then it can possibly be pulled. Usually if it's been in there for 2 or 3 days, then it can probably be pulled. If we just put it in, it doesn't drain anything like at all. Once they come to you, call us, because we can do a quick drain check on it under fluoro, and it takes 5 seconds, and see what the drain is doing. And we also encourage y'all to flush them, because they do kind of clog up. And if you just flush them with like 5 milliliters of normal saline, that helps keep them patent, and they'll work just fine. Again, there's really no drain I can't think of that you can't flush, like with just 5 cc's of normal saline. You will never hurt a patient doing that. So don't be scared to do it. You can tell them I told you can do it. So I think that's pretty much it. Do you have anything else, Amy? Or? Yeah.
On the Mercy procedures, can you
Yeah.
talk a little bit about the different styles?
The difference, yeah.
4 or 5 of them, and like
Yeah.
why you pick one over the other.
Right. So there are different devices that we use to get the clot. What he's talking about is when we have a stroke patient, again, and I drew the picture here, we have the clot here. There's a few different devices that we can use to get the clot out. One of them is, well, there's really two. There's called Solitaire and Trevo. These are called stent retrievers. And basically what they are is they're like stents on a stick. And so you've got a stent that will deploy. And as you know, stents are just like kind of like little plastic kind of things. They're made of, and they've got like this, kind of just dynamic kind of crosshair kind of look to them. So, and they're on a stick. And so basically, when I say a stick, they're on a wire, okay, like this. And so what we'll do is we'll put our microcatheter out here, and then we'll pull our microcatheter back, but we'll keep the stent in place like right here. And as our microcatheter comes back, it unsheaths the stent, so it deploys the stent. So the stent opens up, literally in the clot. And what it does is it takes this kind of cage-like pattern, will kind of cheese grade that clot and kind of push it up against the sidewall, and it'll grab onto it. And so then we'll put suction on this catheter here, and we'll literally pull the stent out. And the stent comes out of the body, and the clot comes with it. And so we pull it out from the groin, and we can actually see the clot. It's pretty cool. And you can see how much clot was in there. And so that's like one way to get clot out. Another way is to use like a special catheter called an ACE reperfusion catheter. It's also made by that company Penumbra that I was telling you about earlier. I feel like I should have had some disclosures before I started this lecture. And the ACE reperfusion catheter it's basically just a special catheter that's a little bit smaller than this one, and it has a more flexible tip. And so when we put this catheter up here, we don't have the stent anymore, we'll just park the catheter basically like right here, and it'll be tunneled through this other catheter, and we'll bump it up against the clot. So the clot's all right here, and we'll push it up against it, and we'll hook it up to a suction machine that will kind of pull this clot in. And once it's kind of grabbed a hold of the clot, then we'll pull the whole ACE out. And you can also see the big clot on that too. So basically, these are the main 3 devices that we're using right now. You said Mercy. Mercy works kind of similar to maybe the ACE, except it has like a little dagger that comes out to kind of break up the clot as it sucks it in. But Mercy is kind of fallen out because we had a lot of complications with it at one point, and so we just don't use Mercy as much anymore. Yeah, it's just these are the 3 that are kind of the more kind of modern ways of treatment.
You choose one over the other.
It just depends. So if somebody is really old, like if they're over like 80s, 90s, then they'll have like really tortuous anatomy here, and so it's hard to pass the ACE catheter up that far because this is a big catheter. It's like a bigger French catheter than the Trevo. The Trevo can get through a microcatheter. This is just probably like a regular 4 French size catheter. So what we'll do with the Trevo is much more navigable when they have like really tortuous anatomy. If they're really old, we'll probably use Trevo or Solitaire. Personally, I think Trevo works better than solitaire, but I mean, that's just me. But I like to use Trevo. But sometimes you can use a combination of the two. We can put Trevo through. It will actually fit through the ACE reperfusion. So we'll actually put Trevo up, and we can actually suction through ACE. That's kind of a new way to do it, but it's just a combination of the two. But when we start using combinations of different types of platforms, is when it gets really, really expensive, and we do try to keep down our costs as much as we can. But at the same time, we're going to do whatever it takes to get the clot out. So that's just how it is. So that was a really good question.
With coilings, they're not all in the brain either. We also do coilings throughout the body. We've had several spleens lately that we've gone in, had people with grade 3 spleen lax. They've come in, kept them for a day or so to see if they'll stabilize. They're not stabilizing. They really don't want to take these people to surgery. They'll send them to us, and we can actually coil the vessel in the spleen that is causing the bleeding.
Any more questions from you guys? Hey. Mm-hmm. That's a good question. Some patients will come with us with high blood pressure, and they may or may not be in control. It's good because we will kind of pick up on that when they come to see us, to try to figure out what their baseline blood pressure is. I'm fine with anything below 140. I realize that it's really hard to get all patients normotensive, and I'm not gonna bang that, or get really upset about if their blood pressure is above 120 or 180. But I would say if it's below it really needs to be kind of below 140. But at the same time, somebody who lives at a blood pressure of 180 every single day, and that's their normal, that's like what they're used to, then it's probably not that big of a deal to get that high. But you might, when you lower their blood pressure to a normal, you might see that they're kind of really kind of somnolent. They're just not used to having a blood pressure that is that low. But we usually can pick up on that and make sure their primary care doctor has a good handle on having their blood pressure controlled before they come to us. But I'm fine with anything below 140.